Welcome to episode 15 of the Pro PA podcast. I'm your host, Prof G, and today we'll be diving back into our pneumonia series with a focus on fungal pneumonia. This episode will give you high-yield breakdown of the most common fungal pathogens, their geographic distribution, hallmark presentations, and evidence-based management. Stick around for clinical pearls and vignette-style questions to solidify your knowledge. Now let's get started. First, let's talk about the kinder patho. What is fungal pneumonia? Well, like we would think, fungal pneumonia is a lung infection caused by fungal pathogens. And when we think of fungal pneumonia, a lot of students tend to get tripped up on it because there's so many different types of fungal pneumonia. We're going to try to stick to the basics here. Fungal pneumonia primarily affects immunocompromised patients, but it can also occur in immunocompetent patients exposed in endemic fungi in specific geographic regions. The fungi enters the lungs via inhalation of spores, causing pulmonary inflammation and granuloma formation, and in severe cases, it can disseminate to other organs. A key pathopearl is that fungal pneumonia is often mistaken for bacterial pneumonia or tuberculosis due to overlapping symptoms and imaging findings. So, who gets fungal pneumonia? Like we just mentioned, immunocompromised patients are going to be the key patient clientele here. Usually, we see this in HIV/AIDS with a CD4 count less than 200. We can see this also in transplant recipients, patients on chronic corticosteroids or chemotherapy, or neutropenic patients. Those that are immunocompetent can also get this type of infections when they are exposed to endemic fungi like Histoplasma, Coccidioides, or Blastomyces in specific regions. Now, what are the common fungal pathogens? Let's break down the key fungal pathogens by geography and by clinical presentation. Let's start with one that I see most often tested in the PANCE or PANRE, and that is Histoplasma capsulatum or histoplasmosis. So, histoplasmosis is often found in the Ohio and Mississippi River valleys. Now, if you aren't brushed up on your US geography, I do suggest Googling this and looking at a map to see kind of the endemic regions. Often in a vignette, they will mention Ohio, Mississippi River, those areas. And it is often associated with bird or bat droppings. And this often happens in caves or in chicken coops. And there are some very specific buzzwords that we will expect to see in vignettes for histoplasmosis. Some of these buzzwords include granulomas, mediastinal lymphadenopathy, and spelunking or cave diving. Now, the presentation of most patients is asymptomatic or a mild flu-like symptoms, especially immunocompetent patients. However, you can get disseminated disease in immunocompromised patients, and these patients can present with fever, weight loss, and even hepatosplenomegaly. I like to think of histoplasmosis. I like to put histoplasmosis because it looks like it has an Ohio in it when you add the O to the beginning because OHIO is in there. So that's how I like to think of histoplasmosis. That's how I remember that it's in the Ohio and Mississippi River valleys. Now, moving on, we're going to talk next about Coccidioides immitis or coccidiomycosis. Now, coccidiomycosis, the geography is also very important. It is often found in the southwestern United States, like Arizona or California, and it's also known as valley fever. The buzzwords associated with this are going to be arthralgias. These patients can get erythema nodosum, and they often mention a desert climate, dry, hot, like the Arizona or California climates. The presentation is often going to be these pulmonary nodules or cavitary lesions, and immunocompromised patients can also get this dissemination. This type of illness can actually disseminate to the skin, to the bones, and even to the meninges in severe cases. Next up, we have Blastomyces dermatitis, and this is also known as blastomycosis or blasto. So the geography for this is also going to be the Ohio and Mississippi River valleys, but they also add in the Great Lakes region. And buzzwords for this are going to be these broad-based budding yeasts. So blasto, broad-based budding yeast. So lots of bees in there. They can also cause some verrucous skin lesions. And the presentation is typically these pulmonary symptoms resembling a bacterial pneumonia, which is why it's often mistaken for bacterial pneumonia. In immunocompromised patients, you can also get some disseminated disease, which often involves the skin and bones. Next up, we have aspergillus or aspergillosis. And the risk factors for this are going to be mainly immunocompromised patients or those with pre existing lung disease like tuberculosis or COPD. And the buzzwords for this are going to be a fungus ball or aspergilloma, hemoptysis, and neutropenia. So, how do these patients present? Well, they can present with an allergic bronchopulmonary aspergillosis, which is ABPA, and this is often seen in those patients with asthma or cystic fibrosis or COPD, and can affect their breathing. You can also get an invasive aspergillosis where you get the fever, the cough, hemoptysis, and it usually progresses fairly rapidly, and this is mainly in neutropenic patients. Moving on, we are going to talk about Cryptococcus neoformans or cryptococcicosis. The risk factors for crypto are going to be HIV/AIDS with a CD4 count less than 100, and we often see it associated with things like pigeon droppings. The buzzwords are going to be encapsulated yeast, and crypto can also cause meningitis, especially in those with HIV or AIDS, CD4 count less than 100. So the presentation is usually pulmonary symptoms like cough, dyspnea, fever, and you can also see sometimes some CNS involvement like cryptococcal meningitis. Last up on our fungal list is going to be Pneumocystis jirovecii, or PJP, formerly known as PCP pneumonia. We are going to talk about this a little more in depth in our next episode, but just to be brief here, some of the risk factors are seen mostly exclusively in HIV/AIDS patients with a CD4 count less than 200. Some of the buzzwords are going to be a ground glass opacity. They can also have elevated LDH and hypoxia with exertion. We also see the bat wing presentation on chest x-ray for PJP. And the presentation is often gradual onset of fever, dry cough, and dyspnea. So let's look at the clinical presentation. Like we mentioned, the symptoms are usually fever, cough, dyspnea. It's common to most all different types of fungal pneumonias. You also can see some hemoptysis or the systemic symptoms like weight loss, night sweats in severe or disseminated disease. And physical exam findings initially maybe not specific, but you could hear some crackles, some diminished breath sounds, or evidence of extrapulmonary involvement like skin lesions or hepatosplenomegaly. And all of these little things can provide clues to help you figure out which type of fungal pneumonia we are dealing with. Now, that being said, in the testing world, in the book world, you're going to notice that they're going to give you what you need to make this diagnosis. It is a lot easier to figure out which type of fungal pneumonia it is in the book world than it is in the street world, okay? Because sometimes we don't remember to ask our patients about where they've been traveling or whether they've been cave diving or not. So just keep that in mind. Try not to get too overwhelmed with the fungal pneumonias. So, as far as a workup, generally speaking, there are some diagnostic testing that we can do, like sputum or bronchoalveolar lavage, where we can collect fungal cultures and stains, serologic or antigen testing for specific fungi like Histoplasma or Blasto. We can also do blood cultures for disseminated disease. Imaging, again, is going to be key, especially in the initial stages of diagnosis. We can get a chest x-ray or a CT, and we're looking for those interstitial infiltrates, nodules, or the cavitary lesions. We're also looking for something like ground glass opacities in PJP. There are also some special tests that we can order based on the more specific types of fungal infections like PJP and aspergillus, like a beta-D-glucan or a cryptococcal antigen for suspected cryptococcal disease. So I want us to, when we talk about management, keep it simple because I haven't seen that many questions diving into the intricacies of the pharmacological treatment of fungal pneumonia. However, that being said, let's keep it simple. Let's start with mild to moderate disease. So, in most mild to moderate disease, like histo or coccidio, we're going to treat with an itraconazole. Okay. Aspergillosis, we're going to consider oral voriconazole, or for chronic aspergillosis. Severe or disseminated disease, we're going to be looking at our bigger guns like amphotericin B, which is first line for severe fungal infections. And after they get that treatment started, then they can transition over to an oral azole after they're stabilized. Now, PCP or PJP pneumonia is treated with trimethoprim sulfamethoxazole or Bactrim, and that is the treatment of choice. We can also add in corticosteroids for severe hypoxia, which is a PaO2 of less than 70. We also are going to give these patients supportive care, oxygen therapy for hypoxia, and the antiretroviral therapy for the HIV patients to restore their immune function. Now, a few quick clinical pearls. If you see ground glass opacities and an elevated LDH in an HIV patient with a CD4 count less than 200, you need to be thinking PJP pneumonia. Geographic history is critical for endemic fungi like histo and coccidio. And the third clinical pearl is you're going to want to treat cryptococcus with amphotericin B and flucytosine for CNS involvement. All right, now let's take a look at a few quick review questions and test our multiple choice question skills. So, first off, we have a 34-year-old man who presents with fever, cough, and weight loss. He recently returned from a camping trip in the Ohio River Valley and has mediastinal lymphadenopathy on chest x ray. What is the most likely diagnosis? Is it A, coccidioides, B, histoplasmosis, C, blastomycosis, or D, tuberculosis? I'll give you a few seconds. If you said B, histoplasmosis, you are correct. This patient was exposed in the Ohio River Valley, and they also have some mediastinal lymphadenopathy, which are classic for histoplasmosis. Question number 2, we have a 40-year-old man with HIV with the CD4 count of 50 who presents with fever and cough. Cryptococcal antigen is positive. What is the best initial treatment? Is it A, Bactrim, B, amphotericin B, C, itraconazole, or D, voriconazole? I'll give you a few seconds. If you said B, amphotericin B, you are correct. This patient is severely immunocompromised and has a cryptococcal infection. Especially in patients with very low CD4 counts, they're going to require initial treatment with amphotericin B. All right, well, I want to thank you for joining me on today's clinical medicine brief on fungal pneumonia. We covered everything from common pathogens to their geography, presentations, and even a little bit about treatment. Make sure to tune in for my next episode where we will discuss HIV-related pneumonia and how to tackle it clinically. If you found this episode helpful, hit follow and turn on notifications so you never miss a new episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. I'll catch you in the next episode.